We're now going to proceed with part 2 of our case discussion and talk about acute headache emergencies and how we can save the brain. So to review, at the end of our last portion of the talk, we had the 67-year-old male with a history of hypertension and diabetes, acute onset worst headache of life, associated with physical activity, nausea, vomiting, photophobia, left-sided weakness, confusion, neck stiffness, nuchal rigidity, abnormal vital signs, and slightly depressed Glasgow Coma Scale. Before we go into the differential, I just want to make sure we understand what the headache red flags are. When someone comes into the emergency department or the clinic, what are the parts of the history, physical exam, that we consider are dangerous and are in need of further workup? Well, the most common one that we see is what we call the first or worse, a new onset headache, or the most severe headache of a person's life. And a patient who doesn't get headaches is something that needs to be evaluated. Now again, it may be a benign cause, but this so-called first or worse headache at least deserves second look and further evaluation. Other red flags are abrupt onset, the so-called thunderclap, severe headache that proceeds over seconds to minutes would be considered dangerous presenting symptom. Neck stiffness, nuchal rigidity, indicating meningeal irritation. Any change in level of consciousness, or we call lethargy, certainly indicates some brain dysfunction, which will indicate some sort of severe disease. Abnormal vital signs certainly can be red flags, and this patient has hypertension, but if you have fever, certainly dangerous ones, or any sort of signs of systemic processes, certainly need to be more concerned. Young or old can be concerning age groups too. If you have a new onset headache or in an age greater than 50, concerned about tumors or hypertensive problems, strokes, and quite young, you worry about maybe tumors and infections. Any relevant medical history certainly also can be dangerous. History of HIV or immunosuppression can put you at high risk for cancers and infection. Any history of neoplasm can indicate metastatic disease to the brain or primary disease in the brain. Pregnancy predisposes to blood clots, and you can even have blood clots in the sinuses of the brain, the venous sinuses. Any sort of autoimmune disorder also can lead to patients to be on steroids and immunosuppressed. So a good past medical history will identify patients that need further workup based on their history. So we went back to our differential and we've sort of narrowed it down to some of these potential dangerous causes. We've kind of put a broad differential here in terms of infectious vascular and neoplasm, and so we'll hone that down even further. I've taken 5 of what I consider high-risk dangerous pathologies or likely pathologies, and we've put them in the grid as you see here. As you can see, bacterial meningitis is one of the intracranial hemorrhage, migraine headache, tumor or mass, and ischemic stroke are all things we are concerned with here. And we'll look at these. Sudden onset, certainly migraines can be fairly sudden in onset, although they can often develop over hours, but they certainly can present quite suddenly. Intracranial hemorrhages can happen, that we call that a hemorrhagic stroke. In addition, ischemic stroke can certainly present with it as well. All of these headaches are of course severe, which is why severe or worse headache of life is something that we worry about. Neck stiffness is certainly part of bacterial meningitis, where infection and white blood cells affect the meninges, and certainly blood itself can irritate the meninges and cause neck stiffness or nuchal rigidity. Confusion, meningitis, hemorrhage, ischemic stroke, abnormal vital signs with hypertension, as you can see below. Any intracranial process can cause this. Fever, largely confined to infectious etiologies, and vomiting present in all possibilities. And focal neurologic findings can be a part of any of these as well. So the one that kind of hits most of the patient is presenting with today is intracranial hemorrhage, and so we are going to proceed with a workup based on that possibility. Now again, just to reassess, we've now done our thinking and then developed a differential diagnosis. We now know which treatments to begin evaluating for, and we need to start acting to help this patient feel better. So what tests would you order based on this patient's differential diagnosis to help identify and narrow down what the etiology of this patient's headache? Well, as you can see right now, we have a list: CBC, electrolytes, urinalysis, coags, lipase, ECG, plain films, ultrasound and computed tomography. I will tell you, for this patient evaluating for potential dangerous abnormalities, certainly would look for CBC, serum electrolytes, urinalysis, coags, ECG, computed tomography. This is looking for potential infectious etiologies, causes of the patient's delirium, and making sure that all of the laboratory tests are otherwise normal and not having any effect on the patient's treatment at this presentation at this time. So, as for therapeutic interventions, please treat the patient's pain and nausea. It's unclear if this patient's blood pressure is at least in part due to pain or a byproduct of this process or caused the process itself. So the first step is to treat the patient's pain and nausea and make the patient more comfortable. That blood pressure is quite elevated, and if the patient continues to have an elevated blood pressure in spite of adequate symptom control, I would recommend lowering the blood pressure at least into a more normal range. When the blood pressure is above 220 systolic, above 110 diastolic, we do try to treat it. And the goal is modest. We're not trying to get it to normal, which could actually cause more harm than good, but we are trying to get it into a more normal, less potentially damaging place. And that, in general, for me, is around systolic blood pressure of 180 millimeters of mercury. That is still elevated, but in a less potentially damaging way. We do get a non-contrasted head CT, which is a first step in the patient's evaluation, and the graphic, as you can see here, does show a highlighted portion of the central part of the brain. Normally, you cannot see this configuration of anatomy in the brain itself, and this highlighted, this dense, this white part here is subarachnoid blood. It kind of looks like a starfish, and that is a starfish sign, and that indicates that there's some subarachnoid blood around the center, the base of the brain, and we would call that intracranial hemorrhage. The remaining tests come back, some subtle abnormalities, mildly elevated white blood cell count, mildly elevated blood glucose, but essentially everything else appears fairly normal. So, putting it all together, we now have a fairly normal laboratory workup, but an abnormal head CT that does show intracranial blood. So while we have our initial differential with a patient with neurologic deficits, intracranial blood, and abnormal vital signs, the diagnosis becomes clear. It's an intracranial hemorrhage, and in this particular case, based on the location of where the blood appears to be, it appears to be a subarachnoid hemorrhage. We'll talk a little bit about that in the next talk. Now, we did find blood on the CT scan on this patient's presentation, and that is a diagnosis, so we know what's going on. That's not always the case. If this patient had a negative CT, you're not in the clear yet. It is important, if the CT is negative and you still have patients with these findings, that you do further evaluation. If CT is negative, you should consider a lumbar puncture or MRI for further evaluation. This can find other etiologies of the patient's presentation, other severe problems, and even can detect some bleeds that are missed by CT scan. CT scan can miss very small bleeds or a bleed that was that occurred The delayed presentation, meaning that the blood is no longer lights up as a dense, bright white part of the brain, but it starts to dissolve and then looks more normal. You will miss those on a CT scan at this time if you ignore further workup and lumbar puncture. Again, CT alone cannot fully exclude a subarachnoid hemorrhage, so be cautious. So, in summary, be aware of the headache red flags. Make sure you go every patient that presents with a severe headache. Make sure you get a targeted history and physical. Make sure the patient doesn't have any dangerous red flags. Benign dangerous headaches can have similar symptoms. Migraines, meningitis can look similar, and they need further evaluation. And again, you often cannot fully identify headache emergencies by symptoms alone. You will need adjunctive testing, and they can help narrow the differential and identify the cause. And at this time, we've identified the cause as patient's subarachnoid hemorrhage, likely influenced by the patient's age, hypertensive state, and that is clinically consistent with a patient who has a severe, new onset, worst headache of life with the symptoms as described above, especially in the context of activity in a near syncopal, near fainting, or fainting event. Identify life-threatening causes of headache and manage them appropriately. And we'll go over a little bit of the management of subarachnoid hemorrhage on our next talk.